Good morning. My name is Brayden Yellman. I am internal medicine and rheumatology trained, and today we will be covering some integrative clinical management of hypermobile EDS, hypermobile spectrum disorders, and their common comorbidities. I work for a nonprofit called the Bateman Horne Center, and we do have some relationships with advocacy agencies and research agencies, but none of those relationships affect any of the content that will be covered today. We, as a nonprofit, focus our care on ME/CFS, or myalgic encephalomyelitis and chronic fatigue syndrome, long COVID, and its related comorbidities, which include our hypermobile spectrum disorders. And we are not recommending any specific products. This is all for clinical management and thought processes. So I really want to dive in today as far as trying to help us with clinical management when we have a complicated patient in front of us. We've already made the diagnosis of hEDS, or a hypermobile spectrum disorder. Dr. Maxwell went over how to make that diagnosis very clearly. So when we've got that, what are some of the key questions I think about when managing these complex clinical cases? And this is by no means exhaustive, but I certainly want to give a little framework to how I think about addressing these patients. There will be a lot covered today that I'm going to go through rather quickly, and we're going to provide resources with entire lectures that will cover the topics in greater detail moving forward. So if there's something that you feel like I didn't touch on fast enough, we will provide those resources for you to go back to a little later. So the first thing I want to touch on is all the common comorbidities we do see in hEDS, or a hypermobile spectrum disorder, and that includes things like ME/CFS, POTS, mast cell activation syndrome, small fiber polyneuropathy, gastrointestinal dysmotility, central nervous system complications, which can be acquired tethered cord, craniocervical instability, and a few others, as well as vascular abdominal pathologies. So we'll try to cover a few of these today, but I want people to be thinking about these comorbidities when approaching a hypermobile spectrum patient. So the first question I ask when I have an hEDS patient in front of me is, does this patient actually have ME/CFS? And more specifically, do they have the pathognomonic feature of that illness, which is called post-exertional malaise? So self-reported data in a cross-sectional study of those with ME/CFS suggests that 15% of ME/CFS patients have joint hypermobility, and 28% of patients with long COVID ME/CFS, so ME/CFS due to long COVID, report generalized hypermobility. And in a self-reporting prospective observational study, individuals with generalized joint hypermobility were approximately 30% more likely to experience chronic symptoms after recovery from SARS-CoV-2, often meeting the criteria for ME/CFS. So there's a very clear relationship between those two illnesses. How do we make the diagnosis? Well, unfortunately, there's no single specific or sensitive biomarker for ME/CFS, but there are core clinical criteria that we use to rule in a diagnosis of ME/CFS, though there are many additional comorbid symptoms, many of which I've already listed for hEDS, that are present. So very quickly, on the right side of the screen here are the Institute of Medicine criteria for the diagnosis. One has to have a substantial reduction in function or impairment in ability to function for greater than 6 months that is accompanied by severe fatigue, but it's that reduction in function that's important in that first category. The second is post-exertional malaise, which we're going to go into deeper, and that is the defining feature that only exists in ME/CFS. Unrefreshing sleep, no matter how much sleep one gets, but sometimes that's disturbed sleep as well, and at least one of the two following, although I would argue most patients with ME/CFS have both. This is a waxing and waning cognitive impairment that is not permanent but comes and goes, often dependent on other clinical features that are happening at that moment in time, or what position the patient is in, upright, laying down, etc. And then orthostatic intolerance, which we're also going to touch on in greater detail. So what is PEM? It's the inability to recover normally following physical, cognitive, or emotional exertion, and it results in a level of fatigue that is even more profound, more devastating, longer lasting than observed in patients with any other fatiguing disorders, or in ME/CFS patients when they are not in post-exertional malaise. Though they have an overall baseline function that is impaired by post-infectious syndromes in ME/CFS and long COVID, they have days that we say good days, or baseline days, where their function is only somewhat impaired, and bad days where function is more severely impaired compared to baseline reduction in function. It's these bad days that are representative of further impaired physiology, and we call those post-exertional malaise. And in that case, cellular metabolism is severely impaired and is primarily anaerobic during this episode. So we actually get augmented symptoms of ME/CFS and new symptoms when we're in PEM. We get flu-like symptoms with subjective fever, sore throats, arthralgia, myalgia, cognitive symptoms including brain fog, word-finding difficulties, trouble with concentration, insomnia, headaches, sensory sensitivities, worsened orthostatic intolerance, and worsening of other symptoms of their complex chronic conditions, including things like mast cell activation. The PEM experience is not uncommon for people in experiencing PEM to remain confined to their bed for much of the duration of that episode of post-exertional malaise. They may struggle to complete their basic activities of daily living, including things like toileting or preparing food. And I've had patients say, when I'm in PEM, if there's a fire in the house, I'm not entirely sure I can make it out in time. So this is not just being tired and lazy. This is literally an inability to do things. So how do we assess for post-exertional malaise? One of the things we do when we bring patients in is we try to ask them about the good days and bad days per month. And of course, in this case, good days are their baseline days. And we ask them, how many days per month are you at your baseline function? And how many days per month are you severely impaired compared to that baseline function? When we look at the good and bad days, how many hours of time are you spending on those days actually upright? Meaning, sitting with your feet on the floor, not sitting with your legs extended, or standing. And that gives you a sense of just how inactive or unable to do things people are. So they may find that on a good day they have 5 hours of upright activity, and on a bad day 1 hour of upright activity. That contrast should really stick out to clinicians. And then really importantly, we have people give examples of activities and tasks they can do on a good day, and cannot do on a good day, as well as can and can't do on a bad day. So perhaps on a good day they can walk around the block with the dog, they can cook a meal for 20 minutes, they can take a shower, but they can't read for more than an hour. Perhaps they can't walk 4 blocks or walk for 20 minutes. Perhaps they can't exercise. Perhaps they can't cook a meal from scratch, but they can make something in 20 minutes or less. Those might be examples. Maybe they can have a conversation for 20 minutes, but if they go for an hour, that's too much. They can drive for 20 minutes, etc. And then on a bad day, they may say, I can't take a shower. I cannot do anything to prepare a meal other than microwave something that's already prepared. I can only walk to the mailbox. I can only read for 10 minutes. And I cannot do all of the things that they can do on a good day. So having people go through and perform this exercise can be extremely helpful in determining if post-exertional malaise is present and what their degree of functional impairment is, and even help you make a diagnosis of ME/CFS. Post-exertional malaise is brought on by exceeding already limited stores of available energy for bodily functions, by either utilizing a lot of energy in a short period of time, such as in one day, or by utilizing just a little too much energy over the course of multiple days until it eventually catches up with the patient. So that can be confusing for patients. They may not always know what is causing their post-exertional malaise. Energy expenditures can be spent through physical activities, but also through cognitive activities, which include social activities, emotional activity, and even orthostatic stressors, being upright when you have orthostatic intolerance, or having a very sensory stimulating environment, such as a restaurant with bright lights, loud sounds, lots of commotion going on at once. All of these things require metabolic energy for your brain to process, even if it's processing those things in a subconscious way. Triggers for PEM include things like exercise, orthostatic stress, cognitive and mental activities, environmental stressors, and even emotional responses, be those good or bad emotions. It requires energy even to be excited on Christmas morning. In severely ill patients, sometimes reading, using a computer, having a small conversation, showering, or even sitting up to eat a meal can be a trigger for post-exertional malaise. Hopefully you don't run into too many patients that are that ill, but I see those almost every day. In managing post-exertional malaise, you've identified this now in one of your patients. It's present in addition to your hypermobility. What do? Well, we prioritize avoidance of post-exertional malaise. We prioritize avoidance of these crashes, because these crashes are actually neuroinflammatory injury. They can stack upon one another, and they need to heal before repeat injury. Repeated crashes over time are associated with a worsened long-term functional prognosis, and there's nothing we can do to actually speed up recovery from a crash other than to not dig in and make it worse and utilize more energy. So surrendering to the crash and allowing your body to heal from that is really important, and it's something that we should be counseling our patients on. So what do I tell my patients? Pacing is critical. Avoiding post-exertional malaise is critical. Remain within this concept of an energy envelope or battery. Modify activities to use less energy. So do activities sitting down or with your legs elevated rather than standing, even if that's chopping vegetables or folding laundry. Rest and recharge between activities. Take breaks every hour. Put your legs up for 5 minutes. Recover before you start something else. Plan activities carefully. Don't put too many activities in one day. Set timers for activities so you don't do something for longer than you know your body can handle. Choose what's important use of your energy, right? Is it really important to drive to the grocery store if you have limited energy, or do you want that time for your family? Set voice reminders and lists on your phone. Sometimes that helps people from going up and down stairs too many times in the day. They'll get up the stairs and then forget what they went for due to the cognitive dysfunction of ME/CFS. And we as clinicians should really help these patients, if they need it, take a leave of absence from work or school. If they need that to get out of a cycle of constant post-exertional malaise, that is one of the biggest things we can do to help them recover, not just from PEM, but do better overall with all of their chronic conditions. So there is nothing that speeds up recovery from PEM other than not making it worse and not fighting or pushing through it. And counseling patients on this is critical. Forcing continued repeated and exertional exercise to combat an underlying decompensated state may seem logical, but actually it only promotes worsened outcomes. So things like the graded exercise therapy or Levine protocol that are sometimes recommended for postural orthostatic tachycardia syndrome do not apply when you have an ME/CFS patient or PEM. It's another reason that it's critical to recognize when this exists. So no graded exercise therapy. And it has been long recognized by clinical providers who treat ME/CFS that continued and repeated episodes of post-exertional malaise within any one individual appear to be associated with a worsened long-term functional prognosis. And so I have a little stubbed toe over here, and it's an analogy I give my patients. If you stub your toe and it's still healing and you continue to stub it every day, you're going to start to have that nail grow back weird. The toe's never going to be the same. You've got to let these injuries heal before they happen again, or things will get worse. So how do we manage post-exertional malaise? So when patients choose to or are spurred to push through their symptoms to the point of repeatedly inducing post-exertional malaise, they may eventually experience a severe or prolonged episode of PEM that even resets their baseline function to lower. So those baseline days or good days are now their bad days, and their bad days are even worse. Over time, continued limitation of PEM or complete avoidance does actually seem to lead to clinical symptom stability or gradual improvements in the limits of patients' energy envelopes so that they can ultimately gain back additional function without triggering PEM. In other words, I challenge patients to avoid PEM through good pacing for 2 to 3 months, and by the end of it, they actually find that their baseline function is better. So you can either get worse by continuing to have PEM, or you can get better by avoiding it. And of course, there's situations in between. Setbacks to watch for. So remember that if there is a successful clinical intervention for a patient that helps a patient feel better, they often say, oh, I feel better, I can do more. And then they go and try to make up for lost time. And then they'll induce PEM. And when they induce PEM, they actually start to feel worse. Now they're at their bad days. And so when they come back and report to you, how did that intervention work? They may actually say, well, I felt better for a little while, and then things got worse. So remember that when you help people improve their function, they can actually trigger PEM even when they're feeling better. So watch for that, counsel that they still need to pace even when they're feeling better with other interventions. And then we have a couple of PEM adjacent pharmacological tools just to touch on. Low-dose naltrexone is sometimes used. This reduces microglial cell activation and inflammatory cytokine release in the brain. We see it clinically reduce aching pain, hyperalgesia, and sometimes brain fog, but it may also help with the intensity and duration of post-exertional malaise. And then we also use dextromethorphan. This is just over-the-counter dextromethorphan without other cold medicines in it. This can sometimes extend the energy envelope, help patients avoid triggering PEM, or reduce the intensity and duration of PEM. We can go up to 15 milligrams dosed 3 times a day. Some people just use it as needed when they hit a point where they feel like, oh, I've definitely crossed that threshold, I'm going to end up in PEM soon. It can sometimes stave that off or make that much less intense or shorter in duration. So another key question. We've identified whether or not the patient has post-exertional malaise or ME/CFS. We're not going to force them into exercise. We're going to help them pace if indeed they have that. What about if they have orthostatic intolerance, either through ME/CFS or independent of ME/CFS? Well, I always check initially hours of upright activity. It's a very simple question you can ask people. How many hours a day do you spend with your feet on the floor, whether it's sitting, standing, or walking? And that is not the same as sitting with your legs elevated, horizontal, etc. That's a really big distinction for people orthostatic intolerance, and you'll find they're always elevating their legs because they think and feel better. So normal healthy people spend about 14 to 17 hours a day upright. People with chronic illnesses like multiple sclerosis, CHF, COPD, they spend about 10 to 12 hours a day upright. And those with ME/CFS or other bad orthostatic intolerance conditions will often spend anywhere from 0 to 7 hours of upright activity. So really simple screening tool for your patients. Additionally, we have patients that we know have hypermobility or have concern for orthostatic intolerance fill out orthostatic intolerance questionnaires. On the left, you can see a orthostatic intolerance daily activity scale. On the right, an orthostatic intolerance symptom assessment. And we have found that healthy controls will have an OIQ score of approximately 11.8 when you add the scores up from these two questionnaires, whereas patients with POTS and ME/CFS will have anywhere from about 59 up to about 70 on their scores. So very big differences that tell you orthostatic intolerance is present. And we see that the more you have reduction in hours of upright activity, the higher the OIQ scores are. So those actually correlate. Another very easy tool to screen for orthostatic intolerance. But I think the best tool, and a tool that we would really like people to start doing in office, or at least at home, is something called the 10-minute standing passive or NASLEAN test. This is a test where you have a patient lay down flat for 15 minutes in a dark room, no access to their phone. You measure their heart rate and blood pressure. You then stand them against the wall, heels about 12 inches from the wall, just leaning straight on the wall. What this does is it activates the muscles in the legs that help participate in venous return. And then you measure people's heart rate and blood pressure as well as their SpO2 every minute for 10 minutes during this test, and also watch for clinical observations. And so during that test, you may see that patients start to develop cyanosis of their extremities become cool, they may start sweating. You'd be surprised at how stressful this can be for someone with orthostatic intolerance, and actually more stressful than standing and being able to shift and move around and activate venous return by using the leg muscles. So this is an example of a 32-year-old woman with orthostatic intolerance who completed a NASLEAN test. And I don't want to belabor this, but just to point out that you can see over time a heart rate increase, and if you see this heart rate go up by more than 30 beats per minute, that is consistent with postural orthostatic tachycardia syndrome. We're going to touch on that in a second. One thing we also watch for is changes in blood pressure over time as they continue to stand. And not only do you see a drop in blood pressure, but the biggest thing you notice is a narrowing of the pulse pressure, or the difference between the systolic and diastolic pressures, from 56 to 13. So what is really going on here in the NASLEAN test? What are we measuring in something like POTS, for example? Well, POTS is often referred to as a disease or syndrome, but it's actually better defined as an adaptive response to upright positioning when the initial functions of the autonomic nervous system are failing to maintain adequate blood flow to the brain and other organs. And in POTS specifically, that adaptive response is increasing the heart rate with upright positioning so that you can increase your cardiac output, you get more blood flow back to where it needs to go to function better when upright, whether it's muscles, brain, etc. So while this increase in heart rate can be associated with palpitations and a host of symptoms related to catecholamine release, which gets that heart rate up, the heart rate increase itself is not the actual pathological process, right? This is the response to the underlying pathology that is happening in the autonomic nervous system. The same is true with narrowing of the pulse pressure. It appears to be a vascular adaptive response to help maintain as much blood flow to the brain as possible when you have dysautonomia and orthostatic intolerance. And it's important to point out that if somebody's NASLEAN test changes over time or is not positive, I would still look back at the orthostatic intolerance questionnaires. I would still look back at hours of upright activity, because as time passes in the course of a dysautonomic illness, patients' adaptive responses may change, and sometimes they even burn out. So such patients may have hypertensive responses to upright positioning. They may even have no measurable vital sign response at all, though when you're watching them on a NASLEAN, you can see the cyanosis in their extremities. They get numb, they get nauseated, they get weak. Afterwards, they can't think or focus great. So looking at those orthostatic intolerance questionnaires and pairing that with what you see in the NASLEAN can also be really important. This is just a reminder that we have done ultrasound studies and actually measured that there is a huge reduction of cerebral blood flow into the brain when heads up upright tilt table or a Nasaline test is performed on ME/CFS patients or POTS patients in general. So for a while there, it was thought that there can't be change due to autoregulation, and that has been proven untrue. So how do we manage OI? We want to improve perfusion, expand volume, constrict blood vessels, control rapid heart rate, and modulate our autonomic nervous system. So we want to, for example, increase free water and sodium in an equivalent ratio to help build up that intravascular volume. One thing that I will use often in clinical practice are IV normal saline infusions. They're often a great, even diagnostic intervention before you're thinking about therapy. When you're asking yourself, okay, someone's clearly orthostatic and they have tons of symptoms. How many of those symptoms are actually mediated by orthostatic intolerance versus one of their other chronic conditions? And how aggressive should I be in treating orthostatic intolerance versus looking at those other comorbid conditions? Do I need to be more aggressive with mast cell, etc.? Also, if you have one of those situations with a difficult to interpret Nasaline test, like we were talking about, where you have a burnout and you don't see the heart rate increases or the pulse pressure narrowing, but they clearly have orthostatic symptoms on their questionnaires. How do they clinically respond? Just do a diagnostic test with IV fluid, and if they feel a lot better and function better, there you go. You know that that's relevant. I also like IV saline because it bypasses the GI tract, as many patients with orthostatic intolerance may struggle to get in enough oral fluid and sodium due to nausea, due to decreased GI absorption, which can happen with mast cell activation, due to GI dysmotility, or just overall fatigue and very few hours spent upright or awake during the day. I also find that fluids can bridge to clinical symptom relief to allow for things like oral fluid and sodium loading or other pharmacotherapies. So I may find that if someone's really sick and they can't tolerate oral fluid and salt, if you tank them up with IV fluids, they often feel better, their GI tract is working better. Now you can shift over to oral fluid and salt and maintain that. I would also say that fluids can sometimes assist with more rapid recovery from things like post-exertional malaise, a surgery, an infection, other clinical insults. There are patients that I serve that sometimes require prolonged IV saline support. It's the one thing that keeps them somewhat functional. You'd be surprised at how often this actually is the case. And in those cases, I will sometimes place a PICC line, although you can get mast cell reactions around that site, and even a surgical port. But if you place a surgical port in a patient that's hypermobile, make sure they put extra stitches in, because I can tell you many times I've seen those ports flip backwards and be inaccessible because the connective tissue is so friable in those areas. When you are then feeling like you can add in oral fluid and salt, we aim for 80 to 100 ounces of free water with about 1,500 to 2,500 milligrams of sodium for this amount of free water. We do this in addition to salt liberalized diets, and here are a few options that people use that are helpful for increasing their sodium intake. Very briefly, if people start having severe headaches or head pressure or vision changes when they're increasing their intravascular volume, stop. There are rare cases where people may have increased intracranial hypertension. The fluid gets in and it doesn't get out, and we'll cover that later. So if that happens, recognize it. It's also important to consider the use of compression clothing to restore intravascular volume and venous preload to the heart. This was a study that was done at the Vanderbilt Autonomic Center, where they looked at compression in the legs, in the abdomen, and throughout the whole body, and assessed how that affected the vital sign changes with a heads-up tilt table test. And as you can see here, people's increase in heart rate continued to decrease, and their decrease in systolic blood pressure got less as you added leg compression, even farther as you added abdominal compression, and then when you put the two together, you got even better symptom control. So even in patients who have hyperalgesia in their legs and cannot tolerate compression clothing, abdominal compression alone may provide huge clinical benefits. And this is just an example of a patient who had no clinical interventions done except for compression clothing. No fluid or salt loading, no pharmacotherapy. You can see this is what her Nasaline looked like without compression, and then when you add compression, the heart rate increase was blunted, the blood pressure changes were significantly blunted, so do not miss out on the effects of compression clothing. We use fludrocortisone, which promotes increased reabsorption of sodium and loss of potassium from the distal renal tubules, and encourages renal retention of free water and sodium to increase intravascular volume. It does have some common side effects of headaches. Of course, watch for that increased intracranial hypertension side effect. Hypokalemia can happen, although if you're using fludrocortisone in combination with a fluid and sodium supplementation, usually there's potassium in that, so you won't get hypokalemic, and you can occasionally get peripheral edema, although I find this very rare. We can also increase peripheral vasoconstriction. So we have midodrine, which is a direct alpha-1 agonist for peripheral adrenergic arterial and venous receptors that causes vasoconstriction. You can see droxidopa works right here at those alpha adrenergic receptors. It does not stimulate cardiac beta adrenergic receptors, and it does have poor diffusion across the blood-brain barrier. And contrast that with droxidopa, which is a synthetic amino acid precursor. It's metabolized into norepinephrine. So it works here instead of directly at that receptor. This norepinephrine is then an agonist for alpha-1 receptors, but also alpha-2 and beta-1 adrenergic receptors. And therefore, you get a vasoconstrictor both inside and outside the central nervous system and increased cardiac ionotropy, which is contractility, via those beta-1 adrenergic effects of norepinephrine. So you get an increase in stroke volume and therefore cardiac output with droxidopa as well. Both great tools. Why or how do I use them? Well, peripheral vasoconstriction is great for reducing abnormal or exaggerated peripheral vasodilation, such as with facial flushing, temperature intolerance that happens specifically in hot showers. We want to support systolic and diastolic blood pressures and improve perfusion to the brain, to the muscles, and even to the GI tissues. So our clinical improvements that we may expect with these therapies include things like improved cognition, attention and concentration, muscular fatigability and lactic acidosis shifts, ability to stand in one place or remain upright improves, GI motility can improve with better blood flow to the gut, blood pressure can improve, and even things like erythromelalgia, which is painful erythematous swelling of the hands and feet, will improve with this vasoconstriction. And you'll see this all the time with rewarming and temperature changes in patients with hypermobile spectrum disorders. These are some common doses, and our side effects can include scalp tingling or itching, goosebumps, other pseudoneurological sensory side effects that are not permanent but just temporary, a little bit of urinary retention, especially with midodrine, and supine hypertension, although this is not nearly as common as the label suggests. All right, orthostatic intolerance management, pyridostigmine. This is another drug that we sometimes use. And where does this come from? Well, it actually comes from invasive cardiopulmonary exercise studies in ME/CFS patients, where we show significantly reduced cardiac preload from impaired venous return, and that is universally present in ME/CFS patients and very commonly found in POTS patients without ME/CFS. Additionally, we sometimes see impaired peripheral oxygen extraction, and that could either be due to left to right shunting or capillary exclusion from neurovascular dysregulation or small fiber polyneuropathy contributing to that dysregulation of blood flow at that level, or it could be due to mitochondrial dysfunction. So when we then look at adding pyridostigmine to these patients in a double-blind placebo-controlled randomized controlled trial, we perform IC petroinvasive cardiopulmonary exercise testing and randomize those patients to pyridostigmine or placebo, we actually find that pyridostigmine improves peak exercise VO2 or oxygen extraction by increasing right ventricular filling pressures and thus increasing cardiac output. So this is the idea behind using pyridostigmine, not only in ME/CFS POTS, but in orthostatic intolerance of all kinds. So remember, pyridostigmine is a drug that inhibits the acetylcholine esterase in the synaptic cleft. It reduces the enzymatic hydrolysis of acetylcholine, and thus you get enhanced cholinergic stimulation of, here, postsynaptic norepinephrine release in the postganglionic synapse. So pyridostigmine also increases venoconstriction and venous preload into the right atrium, which thus improves venous pooling, which you'll see a lot in your hypermobile patients as part of the sagertosis that Dr. Maxwell talked about. It improves skin dustiness, it improves edema that is in those lower extremities as well by improving that venous return to the heart. You also get some increased arterial vasoconstriction with increasing diastolic and perfusion pressures. Pyridostigmine is also postulated to help promote neurovascular constriction to overcome the dysregulation, perhaps due to small fiber polyneuropathy, that reduces peripheral AV shunting and improves peripheral oxygen extraction. In other words, if capillaries get cut off, using pyridostigmine seems to open them back up again, so you get exchange of oxygen and nutrients and removal of metabolic waste products. These are the common doses. Side effects include GI cramping, sometimes loose stool output, muscle fasciculations with higher doses, and you do get a little bit of increased sweating, salivation, and tearing with that acetylcholine presence. Beta blockers. So these, of course, block adrenergic receptors that are of the subtype beta 1 and beta 2, so not the alpha adrenergic ones that are stimulated by midodrine and droxidopa, but they primarily exert their positive effects in orthostatic intolerance and POTS by reduction of catecholamines like norepinephrine on these beta receptors, on the cardiac beta receptors, for example. So it's not always about just reducing the heart rate, although reducing that heart rate can reduce palpitations and related symptoms, but it really is about catecholamine and sympathetic overdrive reduction more than anything, because you could blunt the heart rate down to 50, and if they're still having orthostatic intolerance and you're not supporting it any other way, you're actually reducing their adaptive mechanisms. So there's a role for beta blockers, but be careful with them. And we use propranolol most commonly because it's lipophilic and crosses the blood-brain barrier, and it's often considered first line in POTS, though metoprolol is also a good choice as it's lipophilic and crosses the blood-brain barrier, but think about its blood pressure effects when using metoprolol, if you want those or if you don't want those, depending on what's happening with their vital signs. Some common beta blockers we use, of course, side effects include lightheadedness, dizziness, fatigue, bradycardia, hypotension, bronchospasm in asthma patients. I find this really rare in our our mast cell patients that have asthma, because mast cell mediated asthma is very different than the traditional asthma on the test that we think about that has bronchospasm with beta blockers. Ivabradine is another agent that selectively binds to the cardiac transmembrane sodium and potassium ion channels. These are the funny channels of the sinoatrial node, and it slows that inward conduction of sodium, slowing the overall depolarization during diastole and reducing heart rate. It has no effect on systemic vascular resistance or on cardiac ionotropy. And this is a single center study that looked at using ivabradine to reduce POTS symptoms, and you can see there were huge reductions in a lot of symptoms of POTS with that. You do have to code for inappropriate sinus tachycardia to get that approved. I would say POTS or other orthostatic intolerance fits that definition. Watch for bradycardia, lightheadedness, just like beta blockers. So what about exercise to increase cardiac output and improve cardiovascular tone, right? Well, physiological decompensation from being supine all the time, lack of physical exertion, that worsens cardiac output. It worsens vascular tone. It worsens OI symptoms. So maybe regular exercise can improve cardiac output, right? It improves stroke volume and thus improves vascular tone to support optimal blood flow to muscles and other tissues. So why wouldn't we recommend exercise to treat orthostatic intolerance or POTS? And I would say let's have caution here. Why? Because there's good evidence that exercise in orthostatic intolerance patients who do not have ME/CFS, who do not have PEM, actually does improve these things. But if those patients have ME/CFS, exercise that triggers PEM worsens ME/CFS symptoms in the short term. It negates the physiological benefits you would expect with exercise for OI support, and it can worsen long-term symptoms and prognosis as well. So recognize PEM and don't force exercise on those patients. And this is just a quick reminder that patients with POTS and orthostatic intolerance, there are many, many patients that do not have the other comorbidities that we're interested in, the triad or the penta that Dr. Maxwell was talking about. So here we have hEDS, MCAS, ME/CFS. Those patients are very different than all comers of POTS. So what is recommended in the literature for POTS patients may not apply to this group of people. All right, our third major clinical question: does this patient have mast cell activation syndrome? So what is that? Mast cell activation syndrome is characterized by either a pathological accumulation of mast cells in organs and tissues, and or the aberrant release of mast cell inflammatory mediators in tissues, which is often done in an IgE independent manner. So this is a reminder that hEDS, that POTS, that mast cell all cluster together. Nearly 1 in 3 patients with mast cell activation has a comorbid diagnosis of hEDS in a sample of almost 38,000 patients. And in another study, 66% of patients with POTS and EDS also end up meeting criteria for MCAS. So what is the effect of MCAS in hypermobile Ehlers-Danlos? Well, we have irregular, recurrent, or chronic release of mast cell mediated cytokines such as pro-inflammatory molecules, growth factors, proteases, and these have been linked to hypermobile spectrum disorders and other heritable connective tissue disorders. Mast cells in connective tissues cause microenvironmental changes to the extracellular matrix, including IgE mediated autoreactivity. Mast cell inflammatory changes have been implicated in contributing to laxity of blood vessels with pooling of blood in the extremities, again, related to things like orthostatic intolerance. In families with heritable mutations in genes encoding elevated tryptase, which happens in mast cell, 28% of those patients were also found to have joint hypermobility, which is nearly double that of the general population. So is there something about mast cell that worsens or even contributes to some of these hypermobile conditions? EDS and mast cell activation are often, when present together, comorbid with all these other symptoms: ME/CFS, post-Lyme, POTS, fibromyalgia, migraines, chemical sensitivities, IBS, PTSD, craniocervical and atlantoaxial instability, occult tether cord, vulvodynia, prostatitis, interstitial cystitis, endometriosis, and we think that mast cell is contributing perhaps to all of these pathophysiologies. So in addition to allergic triggers, mast cells can be stimulated to degranulate or release their inflammatory cascade by a wide variety of cell triggers. And these can be anything from bacteria, drugs, food, fungi, heavy metals, organophosphates, viruses, cellular danger signals, even things like UV light in the sun, vibration in the environment, and the list goes on and on. But also, mast cells can respond, be triggered by other mechanisms as well that trigger release of inflammation without traditional degranulation of those mast cells. So they actually can release an entirely different host of inflammatory responses in a degranulation independent manner with different triggers. When they do release or get activated, we think about leukotrienes and asthma, we think about histamine and histaminergic symptoms, we think about tryptase. But in fact, there are over 1,200 different mediators that come out of activated mast cells. And so those effects are more wide-reaching than I think any of us truly appreciate or can measure at this time. It's important to remember that mast cells are found in different tissues, and those mast cells in different tissues are phenotypically different from one another and will behave differently. And in fact, mast cells, activated mast cells, no matter where the initial stimulus is present, may send distress signals via neurological or immunological pathways throughout the body, triggering mast cell responses in distal tissues as well. So mast cells are found in the brain, particularly in the hypothalamus, thalamus, third ventricle, pituitary, and pineal glands. And in mast cell activation syndrome, these mast cells are notably activated and affected by emotional stress via the effects of corticotrophin-releasing hormone. Mast cells also appear to regulate the permeability of the blood-brain barrier. The mediators from these activated mast cells, such as histamine and tryptase, can also activate microglial cells in the brain. And of course, these microglial cells, acting as part of the innate immune system, release their own pro-inflammatory mediators in the brain. Microglial cell activation and neuroinflammation has actually been implicated in multiple brain disorders, including the cognitive dysfunction we see in ME/CFS and long COVID, and just the brain fog we see in POTS, in mast cell activation, in other hEDS patients. So what are some of the clinical triggers? As we talked about, they can be myriad. It can be heat, cold, temperature changes, stress, emotional, physical, etc., exercise, fatigue, food, beverages, drugs, both prescription and illicit, natural odors, chemical odors. I had a patient once that had a mast cell reaction smelling my deodorant in the office. Venoms, infections can trigger this, mechanical irritation, dermatographism is a great example of that. Friction, vibration, and even sunlight. A lot of patients would come to me with photosensitive rashes, rule out lupus, and in fact these rashes will come and go in 20-30 minutes. Those are often mast cell, whereas a lupus photosensitivity will last for days to weeks. What are some of the symptoms? Well, of course, since they affect all organ systems, the symptoms are extensive, and they're often considered ones that you would expect with allergy, asthma, and atopy. And of course, we can take the time to look through here, but they extend much beyond that as well. So what do we do for testing and diagnosis of mast cell activation syndrome? There are diagnostic criteria. They are evolving. They may be changing in the near future. There are some labs that people use and biopsies that we can use to actually make a diagnosis that is worthy of, say, enrolling a patient in research. But what I would tell you is that the serum and urine testing in mast cell activation syndrome is specific for the disease, but is not sensitive at all. Samples that are drawn need to immediately be put into pre-chilled containers and remain on ice. They even have to be put in refrigerated centrifuges. And there are very few labs that are qualified to process in this manner. Additionally, even when you process it correctly, you have to catch symptoms immediately as they are occurring, because these things are transient and shifting, and they're not present 100% of the time, even when somebody has mast cell activation syndrome. So I would say, from a clinical perspective, remember that empiric trials of therapy combined with a clinical suspicion for MCAS can also be clinically diagnostic in a setting where you're sitting there with the patient and you're not enrolling them in a clinical trial. The second thing that I reach for is a biopsy of tissue, especially GI tissue, and you want to do a CD117 stain. This is not a traditional stain that is done, but you have to ask for it. And you can actually go back to old slides. People had an EGD for another reason. They had erythematous mucosa in the GI tract. We have no idea why. Go back and stain it for CD117. You'll be surprised how many times you find mast cells everywhere. Those tests that do exist are serum tryptases, elevated serum histamines, 24-hour urine levels of N-methylhistamine 11, beta, prostaglandin F2 alpha, leukotriene E4, etc. But again, I don't order these very often. in clinic when I have a strong suspicion and when people start responding to mast cell therapies, which are pretty benign. What are the goals of reducing mast cell management, right? Do we just care about the allergies? You know, these patients are fatigued, these patients can't be upright, they have all kinds of problems. You know, doc, my biggest problem is not that I have, allergic rhinitis, but I would say that this is the canary in the coal mine for all of these other problems that are happening in mast cell activation. So what we're really trying to do is we're trying to reduce inflammation at connective tissue interfaces. And that inflammation could be what's leading to increased blood-brain barrier permeability or increased vascular permeability and endovascular inflammation. It could be contributing to increased intestinal permeability with GI translocation. It could be contributing to reduced to breakdown of connective tissues that support joints, muscles, and neurovascular structures, right? So we want to reduce that. We want to reduce new or perpetuated innate immune dysregulation that contributes to ME/CFS pathophysiology. It's really interesting. If you look at patients who took antihistamines during an acute COVID infection, they were much less likely to develop long COVID ME/CFS as a result. We want to reduce symptoms, of course, of allergy, ATP, asthma, and anaphylaxis. We want to reduce triggers for neuroinflammation in the brain and also triggers for migraine headache propagation, which can happen as a result of mast cell activation. It is thought to play a role in cortical spreading depression. We also want to reduce triggers for exaggerated dysautonomic behaviors that mediate orthostatic intolerance, GI dysmotility, and sympathetic overdrive. In other words, bad mast cell makes these things worse. So treating mast cell may not be the entire story. It may not fix a patient with multiple problems, but it's like the flour in the cake. You cannot bake the cake without the flour. So mast cell control and mast cell identification are critical. What are the treatments that we use? We use anything from a low histamine diet, though that's hard to keep on, diamine oxidase to reduce histamine in dietary foods, also reducing leftovers, which are really high in histamine, H1 and H2 blockade. We all know Benadryl and leukotriene blockers. We use a lot of mast cell stabilizers, including liquid cromolyn or compounded cromolyn sodium, compounded ketotifen, or over-the-counter flavonoids like luteolin and quercetin. These are really good places to start if you think a patient has mast cell activation and you want to see that clinical improvement with drugs. Keep in mind, though, that even though these things are designed to treat mast cell, sometimes they can have excipients in them that actually exacerbate mast cell activation, so you get the opposite or paradoxical response. So mast cell reactions to actual drugs are rare, but the excipients in those drugs often cause mast cell reactions. So thorough evaluation of medication excipients, whether it's beta blocker, whether it's omega-3 fatty acids, whatever you're giving them to find tolerated preparations, is really of enormous clinical value and is worth your time as a clinician to go through. Sometimes people will be on a drug and they'll be doing great, and then their pharmacy switches manufacturers and all of a sudden they're having a mast cell reaction. Keep that in mind when managing mast cell as well. We do occasionally use anti-IgE biologics like Xolair. Imatinib is becoming more common at lower doses, but these are more second-line therapies. All right, does a patient have an exaggerated or sustained sympathetic nervous system response? So what would that be, right? What would patients look like with that? Well, they'll have an increased startle response, maybe nightmares, maybe panic attacks, and they'll often say, I'm not in cognitive distress. I don't know why my body is having a panic attack. Definitely ask the question in that way. Emotional lability that they can't understand, muscle fasciculations, especially with orthostatic or physiological challenge, insomnia, having a feeling of being wired but tired. The more tired I am, the more wired I am, having nightmares at night, frequent nighttime awakenings, sensitivities to medications that are independent of the pharmacological action of the drug, like I took Tylenol and didn't sleep for 2 days. Well, that's impossible. Not when you're having a sympathetic nervous system hyper-reactive response to that drug, and even sensory sensitivities. What are some of the tools we use? We use alpha blockers and beta blockers. We can also use ivabradine, which we touched on before, to help reduce some of this signaling. We use benzodiazepines frequently, and this is obviously controversial in kind of traditional medicine, right? Benzodiazepines have all these effects on the peripheral nervous system in addition to the central nervous system. We used to use them for anxiety, but now anxiety is entirely based on neurotransmitters in the central nervous system. Well, in these cases, that's not the case, right? The problem is in the dysautonomia response in the peripheral nervous system. And so the fact that benzodiazepines reflect or affect glial cells, platelets, immune cells, erythrocytes, the GI tract, they improve mitochondrial function. We actually want that. We want them to affect the peripheral nervous system. And so they actually work really effectively, even at low doses, in these conditions, and I have never actually seen a patient that I've put on benzodiazepines with these sympathetic overdrive responses. I have never seen them have a psychological dependence on these drugs. Vagal maneuvers are important. This is just an idea of dipping one's face in a really cold ice bucket or turning the shower to really cold to activate the cardiac vagal stimulation, trigeminal brainstem vagal pathways. This can actually help really improve sympathetic over responses as well. So getting on the neck and the face where you apply that cold is the most important way to activate this reflex. Stellate ganglion blocks are moving into the literature now. This is an injection of local anesthetic into the sympathetic chain, and it can improve blood flow and deactivate or reset sympathetic tone. Local anesthetics are used to prevent sodium influx into neurological cells via voltage-gated sodium channels, and it prevents nerve depolarization and sympathetic signaling. So if a patient receives these and they have an initial clinical response that is mild or short-lived, we sometimes will repeat the procedure in short succession, maybe a couple of days later, maybe a week later. And when you start to do that in succession, you really start to see a change in that overall threshold for depolarization and a reduction in activation of that sympathetic response. Current clinical data on responses in ME/CFS, long COVID, and hypermobile patients is just from case series at this point, so we really do need randomized clinical trials. But I have used these many times in my patients with great success. Real quick word on sleep. Sympathetic overdrive is often the most common cause of sleep disturbances in our patients with ME/CFS and POTS and hEDS. So instead of just reaching for a sedative hypnotic, think about actually blocking sympathetic over response first. And you may be surprised how much clonidine, for example, helps people sleep. Another word is on stimulants. Many of these patients, as we've talked about, have terrible brain fog, and so we use stimulants to help them with those symptoms. But remember that stimulants can really worsen sympathetic overdrive and hypervigilance. So to me, it is generally best practice to implement stimulant therapies only when you've made significant clinical improvements in things like orthostatic intolerance, mast cell, and sympathetic overdrive first. All right. Your patient's sitting in front of you and they've been resistant to treatment for POTS. They've been resistant to treatment for mast cell. What do we do? Well, is that resistance perhaps due to a different comorbidity driving or perpetuating that comorbidity? And I just want to have you think about who is driving and who is the passenger in this case. These conditions all affect one another. Bad mast cell can make POTS really difficult to treat, and you've put all your effort into treating POTS and you're still not getting there. Treat mast cell and now you're going to achieve your POTS goals. Reduce sympathetic overdrive, now you're going to meet your POTS goals. Treat your POTS, now your mast cell's not being fed. Think about how these conditions feed one another and exacerbate one another. If you're stuck on one, move on to another. Does this patient have significant non-visceral pain? I thought this was really interesting. We have looked for small fiber polyneuropathy in patients with EDS. This is 79 hEDS patients that were looked at. 70% met criteria for small fiber polyneuropathy on quantitative sensory testing, and 78% met criteria by an intraepidermal nerve fiber density or skin biopsy. And small fiber polyneuropathy diagnosis can be made definite when you meet both the skin biopsy and qualitative sensory testing criteria, and can be considered probable if you meet one of those two criteria. So this here is a heat map of pain for probable and for people with definite small fiber polyneuropathy. You can see how closely this matches the pain maps for patients with hypermobile spectrum disorder alone. So we really think that small fiber polyneuropathy may be playing a role in this distribution of sensory pain in patients. What do we do for pain management? Well, low-dose naltrexone, aforementioned, is actually really helpful for reducing this. We all know about TCAs, gabapentin, pregabalin, duloxetine, and SNRIs. Muscle relaxants to reduce increased muscle tone can be helpful. Managing migraines effectively, patients do really well with CGRP antagonists, can be helpful tools. But I would also remind you that pain, you don't always need to reach for a pain drug. Improving the management of orthostatic intolerance by improving perfusion to muscles or nerves, improving sleep and its effect on central sensitization, improving mast cell activation syndrome and its inflammation at the level of the tissues, and avoidance of post-exertional malaise, if present, if your patient has ME/CFS, all can play a huge role in reducing pain. I would also bring up that there can be a lot of musculoskeletal pain independent of small fiber polyneuropathy from the joint laxity and instability that alters joint loading and force distribution. We get increased tendon laxity that can lead to difficulty with muscles transmitting power, and muscles appear to need to exert greater force
to initiate joint movements and maintain joint stability. Repeated soft tissue injury from joint instability may lead to local tissue inflammation and repair, and this actually alters nociceptive pain signals with lasting neuroplastic pain responses. And we may also have reduced proprioceptive acuity, which increases risk for further musculoskeletal injury. And this is by no means an exhaustive list, but just some of the examples of types of injuries you'll see in patients with hEDS: joint hyperextensions, subluxations, tendon and ligamentous stretching, tendon and ligamentous tears, spinal kyphoscoliosis, spondylodysplasia, spondylolisthesis, disc herniations. And I would point out, some of our patients may have fusion surgeries, lumbar fusions, cervical fusions. The tissues just proximal or distal to those fusions now absorb way more force and load. They're still weak, and they're often frequently injured. So you get these levels of herniations right above that initial fusion surgery. So watch for that. SI joint, hip, and pelvis malpositioning, hypertrophic and dystonic musculature, with the opposing muscle groups being chronically underactivated and atrophied, all can happen. Physical therapy protocols that address the entire biomechanical chain and its kinesiology are more likely to be helpful for these patients than just focally addressing, oh, your shoulder pain, oh, your hip pain, oh, your specific joint pain. The EDS Society specifically recommends the Muldowney Physical Therapy Protocol. There are others, and working with a specialist who is proficient in this can be incredibly helpful for these patients. All right, does our patient have gastrointestinal complications? So small fiber polyneuropathy, we touched on it before from a pain and hyperalgesia perspective, but it also regulates GI dysfunction, or small fiber nerves do. So when you have a polyneuropathy, you get symptoms. The gut is densely innervated by small fiber nerves, and loss of these fibers can result in all kinds of abdominal and digestive symptoms, including GI dysmotility, postprandial nausea and vomiting, diarrhea, weight loss, constipation, irritable bowel syndrome, GERD, and the list goes on. One study evaluated 129 patients referred to a tertiary gastroenterology clinic, and 49% of these patients were found to meet criteria for joint hypermobility syndrome. An unknown etiology for GI symptoms was significantly more likely in those with joint hypermobility syndrome versus those without. And of some of those patients, 12 of 17 of those patients were eventually found to have delayed gastric emptying. Another study at Mayo on EDS patients found that at least 20% had abnormal gastric emptying, and that could be either delayed or accelerated gastric emptying. It's just dysfunction in general. So what do we do when we find dysmotility? Pyridostigmine, aforementioned, does actually increase motility as well via its acetylcholine effects. Prucalopride is a great drug. Metoclopramide. Okay, there's a black box warning. Don't use this. You're going to get extrapyramidal symptoms, right? If you stay at 2.5 milligrams with breakfast and dinner, less than 5 milligrams with breakfast and dinner, you will never get those side effects. And it can help these patients tremendously, right? If you have diabetic gastroparesis, you need higher doses because those nerves are dead. In this case, these nerves are just not signaling correctly, so you only need a whiff of it to really make a huge difference for people. Some patients end up being really sick. They go on to pyloric sphincter Botox, myotomies, gastric pacers, etc. At least identify these patients when they're really sick and know that this is a real part of their pathophysiology. Treating mast cell can improve dysmotility, and treating or improving blood flow to the gut via midodrine and droxidopa, for example, getting it better intravascular volume will help dysmotility. Remember, when you're thinking about abdominal symptoms, that we can have median arcuate ligament syndrome. Dr. Maxwell touched on this a little bit with his lecture. This is defined by recurrent abdominal pain related to compression of the celiac artery or to the celiac nerve plexus by this median arcuate ligament. Symptoms can be mediated by ischemia, perhaps by nerve compression, or even secondary inflammation or mast cell activation at that level. They've seen mast cells in those tissues, or by other neuropathic mechanisms. And it is clinically characterized by a triad of postprandial abdominal pain, weight loss with a fear of eating, and sometimes you'll hear even an abdominal bruit. It's more common in females in that 4th decade of life. What else can cause symptoms in the abdomen? Well, May-Turner syndrome, which is defined by extrinsic venous compression by the arterial system against bony structures in the iliocaval venous territory, which is most commonly the left common iliac vein by the right common iliac artery. You can sometimes get a partial obstruction that can be asymptomatic, but this changes with volume status, with being supine versus laying down. Over time, right, with mast cell activation. But progression can lead to symptoms such as DVT formulation, such as extremity pain, such as swelling and venous claudication, signs of venous insufficiency, particularly in the left lower extremity. There's also Nutcracker syndrome, another venous compression syndrome that refers to the compression of the left renal vein between the aorta and the proximal SMA. Symptoms include hematuria, orthostatic proteinuria, which is harder to pick up on than you might think, and left flank pain. So remember that these venous congestion syndromes may turn as nutcrackers. Symptoms may vary with position, whether you're upright or supine or side lying. They may vary with volume status. They may even vary with altitude or barometric pressure. I'm here in Utah, and when patients go down to sea level and then come back to Utah, all of a sudden these symptoms of venous compression syndromes can come back. So keep in mind that these are variable. Also keep in mind that imaging for these conditions is imperfect. Why? Because we do imaging in a supine position, and sometimes it's that upright position with the ptosis that Dr. Maxwell talked about that is actually what triggers the symptoms. All right, last question I really think about that we don't want to miss is, does this patient have neuroanatomical complications? And specifically, when I say this, I'm asking, all right, I've done everything I can to treat GI dysmotility, sympathetic overdrive, mast cell activation, identify and avoid post-exertional malaise, to help with orthostatic intolerance. Maybe all of those things individually are helping this patient, and yet their overall trajectory is just not getting better. What is upstream that is preventing all these tools that work in so many patients from really helping this patient in front of me? Do they have a neuroanatomical complication? So one of those is, of course, craniocervical instability or atlantoaxial instability. And this is a manifestation of incompetence or hyperlaxity of ligamentous and bony elements supporting the cervical spine and the craniocervical junction. So either at C0, C1 for CCI or C1, C2 for AAI. And this leads to increased motion at these sites. While CCI traditionally is thought to arise from neck trauma, when you talk to traditional neurosurgeons, abnormalities in expression, structure, and function of the fibrillar collagen in EDS can lead to ligamentous incompetence or hyperlaxity, increasing the risk for mobility of these joints. And it is postulated that collagen or ligamentous incompetence may also be triggered by or accelerated by inflammation related to mast cell activation, although we need more research on that. And I believe Beth Pollack will be talking on that in her next talk. So we get increased mobility and instability that can precipitate deformation now of the brainstem or of the upper cervical spinal cord, which includes the ventral brainstem and can lead to even basilar invagination. And increased mobility or instability can also create traction on the vertebral artery or alter venous or CSF outflow from the cranium. So this is the effect of that motion at that site. And you can imagine that if you are pressing on the brainstem or reducing blood flow in and out or CSF flow in and out of the head, that you will get a myriad of symptoms, and symptoms that maybe cannot be controlled with the mechanisms we've already covered today that work in the peripheral of the body. So when you have CCR AAI, we often see this cervical medullary syndrome, and that can include anything from headaches, neck pain, double vision, dizziness, vertigo, memory loss, tinnitus, dysphagia, dysphonia, altered vision, all the way to numbness and paresthesias, or weakness in the arms and legs, choking, emesis, frequent nighttime awakening, snoring, apnea, ataxia, altered sexual function, altered menses. It's very wide-reaching. Moving on to something that is often found with CCI but is its own independent feature, and this is of course often found in hEDS as well. This is the acquired or occult tethered cord syndrome, not a congenital but an acquired syndrome where we have anatomical restriction of the normal movement of the base of the spinal cord via the filum terminale with tightening or tethering. A healthy filum is a fibrous, collagenous, and elastic band connecting the conus medullaris to the dural sac at the S2 level, but in tethered cord, this filum appears to be morphologically altered with fatty tissue, dysplastic axons called nerve twigs, fat and vascular lacunes, and even congested veins. The pathology is thought to be from forcible flexion, stretching of the spinal cord against this filum, causing tissue damage and repair, causing inflammation, perhaps mast cell mediated, and or altering neurological gene expression. So this leads to a classic triad of symptoms that include neurogenic bladder, difficulty with initiation of urination, retention after urination, etc., lower extremity weakness or sensory loss, and lower back pain. But often one of the things you'll see in clinic is that people cannot walk on their heels or they preferentially walk on their toes. Always look for this in a clinical setting. Check the reflexes in the lower extremities. If you have 3+ reflexes at the patellar tendons, this could be a sign that they may be dealing with this. Lastly, I want to touch on the aforementioned idea of idiopathic intracranial hypertension. We talked about how increasing intravascular volume is good for orthostatic intolerance, except when you have this. So we are finding that there's increasing recognition that many of our hEDS patients have symptoms of IIH. 20% of people with ME-CFS in hEDS actually have elevated CSF pressures upon a lumbar puncture, but 85% of those same patients who did not have elevated CSF pressures on that lumbar puncture did note symptomatic improvements after a lumbar puncture with things like diminished headache, improved fatigue, less brain fog because of the removal of CSF. So it seems like in this case that our definition of what the pressure needs to be considered elevated pressure on an opening pressure with a lumbar puncture maybe needs to be redefined for our hypermobile population. People may be symptomatic and respond to reduction of cerebrospinal fluid pressures at much lower levels than in our kind of traditional, otherwise non-hEDS population. Obstructions that cause this can arise from abnormal venous pathology with venous stenosis or tortuosity, as well as from anatomical impingements. We talked a little about Ehlers syndrome, CCI, spinal stenosis, disc herniations, perhaps even venous congestion syndromes, right? May-Turners or nutcrackers in the abdomen or pelvis may actually be contributing to some venous retention in the skull. So people with ME/CFS or hEDS may have uncharacteristic forms of idiopathic intracranial hypertension that do not meet our traditional definitions, right? They may not have elevated opening pressures on lumbar puncture. They may not have papilledema on an ophthalmology exam. This is a dynamic status, remember, based on what their intravascular volume is, what their positioning is, supine versus upright, whether or not they're having a spontaneous CSF leak that reduces the pressure and then building pressure again. It's actually postulated that many of these patients have spontaneous CSF leaks and develop intracranial hypotension temporarily that's actually arising from this increased pressure. So this is a continuum that is constantly changing in our patient, and it changes the pattern of when they have headaches, what position they have headaches in, what they're responding to as far as feeling better and worse. Like last week you said this made you feel better and worse. This week the symptoms have changed. It's because this is a dynamic and changing situation. Lastly, I just wanted to touch on this infratemporal and jugular venous fossa that was touched on a little bit by Dr. Maxwell yesterday. This is a really crowded area. You've got the anterior jugular vein here that can be compressed upon. You can have mast cell activation in this area. But when there's compression in these areas, you get a lot of nerve involvement too. Look, we've got cranial nerves 9, 10, 11, and 12 that run through this area. We've got the nodos ganglion, which is a ganglia of sensory neurons that are part of the vagus nerve located in this jugular fossa. And that ganglion is responsible for regulating breathing, blood pressure, heart rate, and digestion. So when someone has dysautonomia and all of our tricks to improve dysautonomia are not improving, do they have irritation of this ganglia? When they have cranial nerve symptoms on a neurological exam, is it because there's involvement in this really complicated anatomical area? Do be thinking of this in your most complicated patients who just do not respond to any other therapies. What to do about it is an entirely different question. We have some specialists in this country who are working, and I'm sure in Canada as well, who are starting to get better at identifying these situations and trying to perform things like surgical decompression, but that is an evolving field, and hopefully we'll get better for the sake of our patients moving forward. So with that, I want to thank you for your attention in this very long lecture. There was a lot to cover, and this is by no means exhaustive, but these are some of the main categories that I think help me organize my thoughts and really make a difference in these otherwise extremely complicated patients.